Good evening, my name is Susan Skullock-Hardiman. This presentation is a part of the University of Athabasca's Evaluating Health Research course, and its directed use is for Dr. Juanita Jansen, and all information in this presentation was taken from the University of Athabasca's library. All references can be found at the end of the presentation. Collaboration has had some positive outcome measures for many diabetic patients. This presentation will examine various studies to see what improved outcome measures occur when a pharmacist is included on a collaborative care team. We'll look at various interventions that a pharmacist can provide and assess the overall benefits. From this, we'll be able to make an informed decision on hiring a pharmacist for our team. I apologize in advance for any mispronunciations of surnames included in this presentation. The first study that we'll take a look at this evening is the El Hamarnath et al. Study from 2017. The authors tell us how prevalent cardiovascular disease is within patients who have diabetes. This mixed method study had two outcomes that we will examine. They include the overall difference in the estimated cardiovascular risk and the difference in various lab results. The intervention group received education on diet, exercise, and they closely monitored measurements of glycemic level, LDL cholesterol, and tobacco use was also monitored. From this, they prescribed different medications and made medication changes where necessary. Over a 3-month period, the authors noted the intervention group had an overall reduction of having a major cardiovascular event. The specifics were the intervention group had reduced A1C levels, they reduced both systolic and diastolic blood pressure, they reduced their LDL cholesterol, and tobacco use was decreased compared to the control group. It was also self-reported by the intervention group that exercise endurance had improved when compared to the control group. The second study that we will look at this evening was a retrospective matched cohort study done by Cowart and Santos in 2019. This study focused on time to treatment intensification and how A1C levels were impacted. The intervention involved was medication and treatment intensification. The overall outcomes showed that more patients in the pharmacist-physician managed cohort attained a statistically significant reduction in their A1C levels in less time. There was also a greater change in their A1C levels from baseline when compared to the usual medical care cohort. Epp et al. Completed a dual-center retrospective study where they used a quasi-experimental quantitative design. Measurements were taken from two pre-existing groups and then compared. This cross-sectional study compared two cohorts at various points of time to determine changes in a risk projection for cardiovascular disease within 10 years. The enhanced group had more stringent control measures and medical follow-ups. The pharmacist made medication and dosage adjustments, monitored labs, and provided education on diet and physical activity. They also provided immunizations and initiated outside referrals when necessary for the enhanced care group. For the short term, the study showed that the enhanced group's HbA1c levels significantly decreased from the baseline values. Further, the enhanced care group also had significant improvements in the mean systolic blood pressure when compared to the control group. Therefore, the enhanced care group has shown a reduction in the estimated long-term cardiovascular risk when compared to the controlled group. As I stated earlier in this presentation, the development of cardiovascular disease is a major risk for a person with diabetes. Ladhani et al. Wanted to observe how the intervention impacted the participants' predicted 10-year risk of having a cardiovascular event. The authors focused on various measurements to see which had the biggest impact. The secondary goal was to assess any difference between the United Kingdom Prospective Diabetes Study and the Framingham Risk Score. The primary outcome showed that there was really no significant difference between the two groups after 1 year. The secondary outcome showed that similar results were yielded no matter which risk score you were using. However, the author noted that the biggest reduction of the UKPDS score was attributed to a reduction in the total cholesterol and systolic blood pressure, and not the A1C levels. This result is really significant because it gives us insight to preventing a cardiovascular event for our diabetic patients. The next study that we'll look at is the Laufenberger et al. Study. This study aimed at learning about factors that could explain why a patient would choose one method of controlling their diabetes over another. Patients were given 4 choices. They could choose a treatment intensification, adherence improvements, lifestyle improvements, or they could choose just to not be ready yet. The outcome was to see if there was a change in the HbA1c in patients who had poorly controlled diabetes. Pharmacist notes were used to understand how various interventions effectively decreased HbA1c and the overall adherence to taking their medications. Quantitative findings compared 196 similar patients in each arm. The mean pre to post change in HbA1c was minus 0.48 in the control arm and minus 0.96 for the intervention arm. Qualitative findings used detailed notes from the pharmacist to identify barriers that the patients had. 6 themes emerged. They include issues with diet, difficulty exercising, wait times that affected change to treatment, work-life obligation, lifestyle management issues, and avoidance of medication. These identified barriers are an excellent resource for us when we are treating our patients. Matzik et al. 2018 attempts to show us how collaborative care improves various chronic conditions. Further, the authors also discuss major cost reductions when providing collaborative care versus usual care. The number of all-causing hospitalizations in the collaborative care patients decreased by 31.2% post-intervention. In the usual care group, they only decreased by 8.7%. This result demonstrates a cost savings in favor of having a pharmacist working in collaborative care with other healthcare professionals when managing diabetes. The last study that we look at tonight will be from Schultz et al. 2018. They compared outcomes associated with pharmacist-managed diabetes versus the usual way of care in a retrospective observational cohort study. Education and medication adjustments were the primary intervention methods. The usual care had an average increase of 1.53 of A1C levels versus an average decrease of 1.63 in those in the intervention phase. If we examine the secondary outcomes, we can see that the overall hospitalizations due to diabetic complications were substantially less for those in the intervention phase versus those in usual care. As seen in the previous study by Matzik et al. 2018, a significant cost savings for both the patient and the healthcare system are associated with less hospitalization. In summary, many of the studies we have evaluated have similar findings. When we compare 2 cohorts of patients where one group had intensified treatment with a pharmacist, we've consistently seen improved levels of A1C levels, decrease in both systolic and diastolic blood pressure, a decrease in LDL cholesterol, improved medication adherence, and improved lifestyle, which all decrease chances for a cardiovascular event, thus resulting in an overall decrease in diabetic-related hospitalizations. In conclusion, this presentation has shown that pharmacists do so much more than just prescribe medication. They help educate our patients on diet, exercise, and various lifestyle changes. They're able to provide medication reviews and give information on new pharmaceuticals to treating physicians. Hiring a pharmacist for our team not only will save us money through efficiency, but allow us to provide better patient care. This concludes my presentation. If you have any questions regarding the information provided, stay tuned for my references or you can contact me via email for further clarification. Thank you very much and have a good evening.